Good afternoon, everyone. Welcome to Medical Grand Rounds. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which we now gather. Just a reminder to please leave your questions until the end, enter them in the chat, and Dr. Brophy will answer them. And as well, please answer a brief survey that will be sent to you after Grand Rounds. It will let us know that you were present today. And finally, I'd like to invite Dr. Robin Tamblin to introduce our speaker today. Robin, go ahead.
Yes, thank you very much. It's a true pleasure to be able to introduce Dr. J. Brophy. Dr. Brophy is a professor both in the Department of Medicine and the Department of Epidemiology and Biostatistics, where he's been known to teach some very advanced courses in that department. He is a cardiologist and he does research in cardiovascular epidemiology. His research interests are wide, and they include outcomes research, pharmacoepidemiology, Bayesian statistics, health technology assessment, economic analyses, and clinical research. He's held the FRQS chair in health technology assessment and evidence-based medicine from 2008 to 2023, and he is a fellow of the Canadian Academy of Health Sciences and the Canadian Cardiovascular Society. So thank you so much, Jay, for offering to provide this presentation today. I'm very much looking forward to it.
Thank you very much, Robin. So let's begin. It's a pleasure to be here and talking about one of my favorite subjects, Bayesian statistics and how it relates to meta-analysis and metacognition. The learning objectives. The first third of the talk maybe will be a little bit dry, hopefully not too dry, but we'll try and approach a little bit what is Bayesian analysis, what is its role in metacognition, and then we'll get to some clinical examples, 3 clinical examples, which fortunately probably for most of the audience is not all, they're not all cardiology related. But probably the best place to start and get a good overview of this is to listen to a little rap music. Now, I'm not a rapper, and I typically don't listen to rap music, but this is rap music for nerds, and it's pretty good.
Generated. So perception, figuring out what's there, has to be a process of informed guesswork in which the brain combines these sensory signals with its prior expectations or beliefs about the way the world is. The world we experience comes as much, if not more, from the inside out as from the outside in.
Let me show you how to be a good Bayesian. Change your predictions after taking information in. And if you're thinking I'll be less than amazing, let's adjust those expectations. What's a Bayesian? It's someone who cares about evidence and doesn't jump to assumptions based on intuitions and prejudice. A Bayesian makes predictions on the best available info and adjusts the probability, cause every belief is provisional. And when I kick a flow, mostly I'm watching eyes widen, maybe cause my likeness lowers expectations of tight rhyming. How would I know unless I'm rhyming in front of a bunch of blind men dropping placebo-controlled science like I'm Richard Feynman? Is it because of my looks or the fact that I talk like I'm mad for books? Either way, in the ecosystem of rap, I'm the platypus, so my patron saint on stage is Reverend Bays. Just watch me update the predictions in everyone's brains, teaching a crowd about probabilistical statistical science. For instance, if the president's a proving degenerate liar, remember your priors and be skeptical whenever he's testifying. Is it always inaccurate? No, but you discount outliers, especially when he's testifying about non-citizens, Muslims, African Americans, and other victims of dog whistling, bigoted, unconscious bias, unreliable information. The antidote is to learn how to think like a Bayesian. So let me show you how to be a good Bayesian. Change your predictions after taking information in. And if you're thinking I'll be less than amazing, let's adjust those expectations.
So that's actually probably the highlight of the talk. But anyway, yeah, no, this is rap music. He quote the Brinkman calls it rap music for nerds, which is maybe why I really like it. Oops, let's try and go forward if we can. There we go. So meta-analysis, I think most of us feel we have a decent idea of what that is, a statistical method to combine studies, estimate some common effect, the relative risk that drug A is better than placebo or drug B, and some measure tau of the between study variations, right? And so this common effect in these slides often will be referred to as theta. And meta-analysis is super common. This summer, I had a look in PubMed. There were more than 30,000 publications with meta-analysis in the title in the first 6 months of 2025. And I think we can assume that they're not all of great quality. But nevertheless, most of these are done using conventional statistical methods, which is called frequentism, and that has certain limitations and assumptions that people aren't always aware of, or they are, but they forget about them. And one is that this parameter, this effect we're measuring, is assumed to be a constant, unknown, but constant. And what's random are the data. Seems a little bit bizarre because actually what we have in hand are the data, and the data are the data. They're not really random, but nevertheless, that's the paradigm that's used. And consequently, the 95% confidence interval that people report with these meta-analyses, and indeed any study that uses frequentism, is not a property of the parameter you're measuring, but actually of the procedure you're doing. In other words, if you repeat the study many times, 95% of these intervals will include the parameter theta. Unfortunately, you don't know if the one you're looking at is one of the 95% or one of the outliers, but we've kind of tended to overlook that. Some of the other problems with that sort of frequentist paradigm includes that we can't include prior knowledge if we have some. Often it's combined with null hypothesis significance testing, and I think we're kind of a little bit aware of some of the dangers that holds. But ultimately, we can't make the sort of statements and inferences that we would like to. Like, how likely, how probable is it that I'm going to see a clinically meaningful effect? We can't get those answers from the traditional meta-analysis. The Bayesian meta-analysis, on the other hand, overcomes all those limitations. Nothing free in life, so it does come with a price. And the price is you have to have a prior, and the computations can be more complex. Although now with modern computing and software, that's less of an issue. Metacognition is perhaps a term that we don't see as often as meta-analysis. And really that's the definition, I guess, is sort of in 3 words, is thinking about thinking. Right. So traditional thinking or inference asks, is there an effect after we see some meta-analysis or some RCT? And we might be faced with a data that says the relative risk is 0.82 with some confidence intervals. In this case, the confidence interval crosses 1, so the p is greater than 0.05. And the typical thinking says, okay, p is greater than 0.05. This is a negative study. Well, metacognition attempts to sort of extend this thinking with a more purposeful reflection and put it into context or situational awareness. And among the elements that comprise that would be a recognition that p greater than 0.5 doesn't imply clinical irrelevance, right? Could be p is greater than 0.05 because your study is underpowered, right? It also encourages you to look beyond just the simple summary of the data and say, is this effect large enough to matter? In other words, what's the probability of a benefit? Is the probability of a benefit greater than whatever my minimally clinically important difference threshold might be? And ultimately, I think it facilitates decision-making, whether we should act, wait, or gather more evidence. And this metacognition is fitting into this sort of taxonomy of learning, where if we just remember facts and we kind of understand them, we're at the lower end of the pyramid. Really, the metacognition is at the top two layers, where we're appraising the evidence with some sort of critical judgment, and we're going on to think counterfactually in the creation of new ideas, right? And concretely for clinicians, I think this metacognition is sort of helps us to question the assumptions, to integrate and account for uncertainties, to move beyond just binary assessments, significant or not, into more probabilistic thinking, and ultimately to perhaps help us tailor decisions to specific patients or specific contexts. So in summary then, metacognition, I think, is our destination, right? And that is, I think, the idea of having clinical wisdom that goes beyond the number, beyond relative risk of 0.82, and to provide some sort of deeper understanding and enable us to have better communication and ultimately to make wiser decisions. The Bayesian meta-analysis, I think, is our statistical engine, our GPS, to help get us to this destination. It helps us navigate this uncertainty with a certain principled purpose. So why Bayesian? Well, why do we get these? Why do I say we get better decisions? Well, I think it's because we have a more principled accounting of our assumptions and our uncertainty. The Bayes theorem really just follows the laws of probability, where it enables us to combine data with our prior information, which reflects how humans learn. In any case, we learn in a very cumulative manner. A Bayesian approach can model many more complex data generating processes than traditional statistics. And as I said, ultimately, it enables us to make probabilistic statements. The caveats, as we said before, particularly if you have little data, priors can be very important, and we have to be very careful how they're chosen, and we have to check them for robustness, and there are some computational issues. So this is the key slide about what the Bayesian world is about. You start with a prior, what you believe in before you see the new evidence. The likelihood is what is the new evidence saying, and the posterior is what you're believing after the two. And really what you're doing is nothing more than taking a weighted average of the prior and of the likelihood, right? That's, ultimately what you're doing. Now, this slide is, it's kind of been inversed a little bit, because the prior is always taken as being the Achilles heel of a Bayesian analysis. I would actually argue that it's a strength, because without the prior, you cannot make probabilistic inference. You can't have this cumulative learning, and it forces you to state upfront what are your assumptions. Okay, whereas traditional statistical analyses, they all have models, they all have a zillion assumptions, but they're all hidden from you. Whereas the Bayesian one has one big assumption, the prior. Then there are some assumptions about the model as well that you see in traditional. But it forces you to put that up front. And then people can judge, is this prior reasonable or it's not reasonable? Is this prior been tested for its robustness or not? So, I would say that this idea of a prior being criticized as being subjective is not necessarily totally accurate. If you compare meta-analysis frequentists to Bayesians, there's really only a couple of things that I think are worth knowing or remembering. One is the interpretation of the parameter that you're after, the effect that you're looking for. In the frequentist world, it is a fixed quantity. It's unknown, but it's fixed. Nature has fixed this. The Bayesian says, you know, this variable I'm after, it's got some variability in it. It doesn't have a fixed value. It's a random value. Right? And, you know, we have to put some probability limits on it. That has an impact on the interpretation of the confidence intervals that you get with the frequentist analysis and the corresponding confidence intervals you get in a Bayesian analysis, which are often called credible intervals. But the difference is that what we think and what we want to get, that there's a 95% probability that the true effect lies within that 95% confidence interval, is only attainable in the Bayesian analysis, right? And it's only the Bayesian analysis that can give you probability statements like, how likely is this to happen? How likely is that? You can't have those sort of statements with a frequentist because there is no variability. The parameter is fixed, unknown, but it's fixed. So you can't make probability statements. Consequently, if you want to get into making more tailored inferences, you're really in a bit of a bind in the frequentist analyses. So other than kind of giving you things to sort of twist your mind, do these differences really matter? Okay? So consider that relative risk and confidence interval that we have there. How do we interpret that? Well, from the frequentist point of view, it says that 95% of these confidence intervals are going to include that true effect if the studies were repeated. So it's, you know, hence the name frequentist, it's the long-term frequency. But for this single study, the parameter is either in there or it's out of there. You don't know, right? And it's just as likely to be at the 0.7 as it is to be at the 1.03, right? We don't know. Whereas the Bayesian credible interval really is what we think we're getting, right? Where it's much more likely to be in the middle, and it really reflects the probability of the relative risk given our prior and given our data, right? And of course, we don't have to look at just one point at relative risk of 1 or risk difference of 0. We can do assessments anywhere along that probability distribution, right? And the probability is just the area under the curve to the left or to the right of our line. So we have much more flexibility. Another element in meta-analysis that we don't see very often are prediction intervals. Now, we're all, I think, used to seeing the forest plot, and we want the bottom line is that little line at the bottom that gives us our pooled average. And we usually stop there. Okay, but that gives you the typical average effect that you expect. But if you're more interested in what's the effect or where is the next study likely to land, well, that's not seen by the average because the next study may or may not be average, right? You have to take into account the between study heterogeneity, and you get something called a prediction level or predictive interval, which automatically, I think you can realize, since you're including between study variability, it's going to be wider than the pooled average, which is maybe one of the reasons we don't see it very often, because we like to feel we have the final answer. However, there are many reasons why that should be routinely reported. And a couple of references there that are really quite good at explaining why this is important. Again, there are slight differences, although you can calculate prediction intervals in a frequentist paradigm as well as in a Bayesian paradigm. Their interpretation is slightly different. The frequentist, it is the probability of the next study. Typically, it's 95% intervals that are given. It's the probability that the next study's outcome will fall in this interval if the estimated fixed parameters are correct. May or may not be correct. The Bayesian interpretation is that there's a 95% probability that the next study's outcome lies in this range, given our observed data and our prior, right? So no free lunch. They both come with their own assumptions. I think the Bayesian assumptions are a little bit more palatable, but that's open to discussion. So we got through the first 10 or 15 minutes of the more theoretical part. Now let's talk about some clinical examples. Colchicine, very old drug. Cardiologists just seem to be discovering it in the last sort of generation, whether it's to treat pericarditis or to give to post-acute coronary syndrome patients. But here's a meta-analysis from 2022 of 7 studies, 7 RCTs. The biggest RCT is Colcut, which had about 4,700 patients, dwarfed the other studies. Colcut, I'll remind you, was done during COVID at the Montreal Heart Institute. I think Jean-Claude Tardif deserves a tip of our hat to have managed to do this during COVID. And they found at the end of the day, meta-analysis says that this works and it prevents secondary events, MACE, major adverse cardiovascular events, in patients who are known CAD, and it does so in a rather dramatic fashion. 0.73 confidence intervals, far removed from 1. If somebody is interested in a p-value, lots of zeros in front of this significant digit, right? So their conclusion is that colchicine significantly, I'm not sure exactly what they mean by significantly, but that's what they said, significantly reduce the risk of MACE in coronary patients. So here's a question for you. You have that meta-analysis. Does this mean that the colchicine ACS story is over? That we have the answer? We should be giving colchicine to all our cardiac patients if they've had a coronary event? Is it even ethically justifiable to continue doing research? Well, I would say maybe we shouldn't go quite so fast. There, as you recall, looking at that, we have the average effect here, but there's no mention of what the next study might show, that prediction interval. Also, this is a frequentist analysis, so we're assuming that all the parameters are known with complete certainty. If you do a Bayesian predictive interval, you find out that the next study actually could fall anywhere between a 65% decrease and a 29% increase in risk. So I would argue that the Bayesian there provides a more realistic view of the heterogeneity and justifies doing further studies. And indeed, there was a further study, which was published in January of this year, led out of McMaster. They randomized 7,000 patients, which was more than the combined total, or approximately the combined total of all the patients that were in that 2022 meta-analysis. Looking at the same outcome, CV death, MI, stroke, or urgent revascularization, and they came up with a relative risk of 0.99. Your p-value is 0.9. Their conclusion, treatment with colchicine when started soon after MI and continued for a median of 3 years did not reduce the incidence of the composite primary outcome. Okay. So that's a little different than the meta-analysis. But before we jump just onto this CLEAR trial, the most recent and largest trial, I think we should remember that absence of evidence is not evidence of absence, right? And so rather than looking at the p-values, even if we want to stay just in a frequentist mindset, we should look at that width of that confidence interval and sort of say, yeah, but it could be 15% better, it could be 16% worse. So even though we have 7,000 people, maybe we don't have a definitive answer if we just look at that trial by itself, which is how it was reported, right? It's reported in New England, and in New England, you just report your study because it's only your study that matters. Now, some questions come to mind. Were the clear investigators Bayesian, like me, and they did a prediction interval and sort of said, oh, even though there's that meta-analysis which says we should be giving it, we don't believe it. Well, they didn't believe that the story was over, but they're most definitely not Bayesians. And they're not Bayesians because when they discuss their paper, they just talk about their results. They don't talk about any prior information. They mention in the discussion that there was one other major trial, the Colcott trial, but they don't say anything other than that, other than our trial was bigger. We had 7,000, they only had 4,000. But there's no idea that they are synthesizing evidence according to a Bayesian. Now, although they didn't consider previous evidence, lots of people have been interested in this. And since January, there have been 10 published meta-analyses of this question. Okay, 9 of them have concluded that colchicine is beneficial. One of them said, we're not so sure. I show you one here for several reasons. One, it was published in the European Heart Journal, which has the highest impact factor for any cardiovascular subspecialty journal, 36.4. I don't think I've ever had anything published in the European Heart Journal, so maybe I'm a little annoyed with them, but anyway, they're right up there. The conclusion was that colchicine reduced the composite endpoint by 12%. No mention in the abstract of the uncertainty that goes around that 12%, just that it decreased outcomes by 12%. That's all you have to know. But there's something else that really strikes me even more than that information. And I've given you a clue because I've highlighted some names. And unless you're in the cardiology field, you probably don't know, but those names are all cardiologists who work at McMaster, who did the CLEAR study. And so this study, this meta-analysis, was published 3 months after CLEAR. No other studies were published in the interim. And what we see here is apparently frequentist statistics allow these investigators to declare both that the treatment does not work, as they published in the New England, and 3 months later to simultaneously declare that it does work and gives you a 12% reduction, all with the same available evidence. It's fascinating. We should definitely, if this is true, we should definitely all buy into frequentist statistics. I mean, this is craziness. And how does this come about? Yeah, it comes about because we're not thinking like a Bayesian, right? Where we're accumulating progressively evidence. Now, the Bayesian analysis is not that difficult, actually. We have the standard difficulties that you have in a frequentist analysis, searching the literature, making sure that the studies really are combinable, assessing the quality of the studies, the old, garbage in equals garbage out, and being mindful of that. That's the same as in a frequentist. The additional difficulty is we have to define our priors, right? Now, there are many ways we can do that. We can have what we call vague, non-informative priors, which just let the data dominate. Or if we have some good outside information, we can bring that in. We then specify a likelihood model. You have to specify a model when you do a frequentist meta-analysis, random effects, fixed effects. What we do, though, we have another step where we combine the likelihood and the posterior and the prior. We saw that with the pandas there. But that is pretty straightforward now with these numerical methods that we have. Really not that difficult, but then we end up with this posterior distribution, which we can really do a lot of good stuff with. Now, just to underline that the computational part is not that difficult. It's 1, 2, actually I could have written this line all on one line. It's like 3 or 4 lines of code. It's not that difficult. We can do full Bayesian analyses now that are using MCMC on, I don't think you can do it on your phone. Well, yes, actually you can. You go to some of the clouds, and you can do it. But we can do all this, right? But we just have to conceptually wrap our minds around, our heads around the idea of doing it. So let's look at Colchicine. One of the things I said is you want to make sure of your priors. So in this case, I looked at 3 different priors. This is to help us assess how robust our conclusions might be. So we can start with a vague prior, which allows the clear data to dominate by itself. And essentially that's what you have with the blue curve here, right? And this gives you pretty exactly what you had with the frequentist analysis. The most likely point up here is like 0.99, and we can get a credible interval which approximates what they had in their confidence interval. But what we see is if we look at the area under the curve to the left of this line 1, it's 58% of the area. So rather than say from our study, as they did in the New England, clear colchicine doesn't work, if you do this analysis, you say, you know what? It's kind of a coin toss. There's a 58% probability that we might have some benefit, right? Now, if you did take the data, the prior was the cold cut. Remember, that had about 4,500 patients, had a very big effect of about 0.72 or something. If you take that as your prior, combine it with the data, the blue, you get a weighted average, and you get the posterior with a cold cut prior that is given by the green curve. And here we see things have shifted because of this, the weighting we're getting according to the prior. And now, if you look at the area under that curve to the left of this line, it's about 92%. Okay, so there's about 92% probability that colchicine works if you use that as your prior. Well, the same thing if you used the meta-analysis. Okay, there were the 2022 meta-analysis. There's more data, so the curve is a little bit tighter. The results were a little bit more positive than just in cold cut. And you combine that with the blue, with your likelihood data, your new data, and you end up with the orange area here. And now you're almost totally certain that the probability of a benefit, the risk ratio is less than 1, is pretty close to 100%. There's almost no area to the right of that line. Okay? So, but it doesn't really answer our question so much, because we're kind of more interested in, is this difference clinically significant? Right? And actually, we can look at that. We can, because we have this posterior distribution, we don't have to cut the line at 1. We could cut it at 10% decrease, at 0.9, at 0.85, and measure the area under the curve. And indeed, if we do that for a whole bunch of different scenarios, we can generate probabilities. For example, the probability that there is at least a 15% decrease in cardiovascular events with colchicine, if we just look at clear, is minuscule. If we include data from cold cut, then it's about 11%. If we include the whole meta-analysis, it's about 40%. So I would put forward, and if we look at clear just by itself, we saw that there's about a 58% probability that the relative risk is less than 1, versus the New England just reporting p equals 0.93, no effect. I think it's a little bit more informative to us to have gone through these extra Bayesian steps to really understand the data and what it's telling us, right? And so what we can see from all this is that this idea of just in the European Heart meta-analysis just saying there's a 12% reduction with no measure of the uncertainty is just unhelpful. That this sort of Bayesian approach of posterior probabilities really informs your decision making. And so if your own minimally clinically important difference is you want a relative risk reduction greater than 15%, it doesn't look like that's likely to happen. you might want to wait for more evidence before you start giving colchicine to your post-MI patients. If your minimally clinical important difference is less than 15%, then, like in here, it's 10%. Depends a little bit on your prior as to whether it's only 10% or even up to 80%. Then I think you should have an honest discussion of the uncertainty with your patient and maybe decide to target the highest risk of them, because of course the relative risk will have more benefit applied to higher risk populations within there. But in either scenario, I think this helps inform your decision making and the sort of discussions that you can have with your patients. Enough cardiology. Let's go, I have to move a little quicker, to stroke. So guidelines now recommend giving thrombolysis if somebody presents with a stroke and their symptoms are within a 4.5 hour window of onset. There have been 6 RCTs that have looked at extending this window beyond 4.5 hours, guided by advanced neuroimaging. And interesting, there's been only 6 RCTs, but we still have 7 meta-analyses. And they've all concluded that there's benefit to doing this. Now, we should remember, of course, this sort of garbage in, garbage out kind of thing, and that if we look at the Cochrane risk of bias, all these studies have some bias in them, performance bias, largely because they're open label. The other biases are often because these trials have been stopped prematurely. We often think that a trial stopped prematurely gives us added evidence that this must be a really strong effect. But it's actually quite the inverse, that if you look at the same study that has been truncated and gone to completion, okay, the completed trials are always much, much less favorable. Okay, and indeed, if you have a small number of outcomes, the truncated trial can overestimate the effect size by even a factor of 5. Now, in this case, we weren't looking at that element of bias. That will take our Bayesian method into the third example. Here we're looking at how these studies were done and how they were analyzed when they were pulled together. And all these studies looked at a modified Rankin score. And essentially, they all dichotomized the results. They said if your score was 0 or 1, you were okay. If you had anything from 2 to 6, you were bad. Okay, and so they dichotomized this outcome. Now, I think you might argue that if you have a slight disability, but you can still look after your own affairs without assistance, it's not exactly the same thing as being dead, right? Okay, but nevertheless, all the trials have used this as their metric. Okay? And all the meta-analyses have taken all the trials and just brought them together. But we're obviously losing, and this is just a typical example, we're losing information. We have information, more granular information about each of the different stages that these people might be in after treatment, either with treatment or without treatment. And we're throwing it out, and we're not making any sort of probability statements. So this is a typical meta-analysis from this year of this data in March. And intravenous thrombolytic therapy for stroke beyond 4.5 hours leads to an increased odds of excellent and good functional capacity and a non-significant numerical increase in mortality. Okay. I think we should be clear that a non-significant increase in mortality is not the same as no increase in mortality, right? Okay, but this is what the frequentists put forward to us. But we can do better, right? We can do ordinal regression, where we look at each of these categories, and patients have actually rated these categories and given them utility weights from about 4 different studies. And so we could take each of the rather than looking at the patients, either they're in 1 and 2 or greater than 1, we can look at each individual class, how many were in each of the different categories, multiply it by their utility weights, and work with a score like that. This is easy to do in a Bayesian context. You can develop all sorts of complex models it's much trickier to do this in a frequentist world. We can also learn from these studies that for stroke and for the utility-weighted modified Rankin score, the minimal clinically important difference threshold is a score of greater than 0.09. So we did a meta-analysis. The slide looks busy. Usually you would just see sort of the blue lines. You wouldn't see any of the green lines. The green lines actually just show you how each of the studies are impacted by the other studies, because there's this borrowing of information, because this meta-analysis lies within a hierarchy. But ignore the green, I won't say ignore the green lines, all of them, because the bottom ones are just given in green. But we can see the pooled average, which in this case does not touch 0. So our Bayesian meta-analysis would agree with the 7 previous ones that even using a utility-weighted score, there's a benefit for thrombolysis. We have a little bit more uncertainty, because if we do the prediction interval, we see that, the next study, it might be not so favorable. So even though we have a pooled result, which is keeping with the frequentist, we're kind of a little bit in the uncertain area, that then maybe there is some uncertainty here. But more importantly is when we start looking at the upper limit of this, because now, unlike the frequentists, we can view this as a probability distribution. We can talk probability. They can't. We can, because we've made some assumptions about our priors. In this case, we assumed a non-informative prior, but so we can talk about that. And we notice that the 95% confidence interval, or credible interval, goes up to 0.09. Remember, the minimally clinically important difference was 0.09. So we can turn this into a slightly different graphic, and we can show that essentially that we're almost totally sure, about 98% sure, that there is a benefit for thrombolysis, okay, using this weighted score of all the people, not necessarily grouping them arbitrarily 0-1 versus not. But we can also see that at the 0.09, there is a trivial advantage, so that really it doesn't look like there's any clinical advantage beyond what we would like to see as a minimally clinically important difference. On the other hand, remember that mortality thing. So this is for the utility weighted of a modified Rankin score. What about mortality? Well, we can do the same sort of Bayesian meta-analysis looking at mortality. And at the end of the day, down here, we can see that for the pooled average, the bulk of the area under the curve is on the wrong side. It's an increased risk of mortality. And it's about a 76% increase in mortality. Now, we could also apply what is a minimally clinically important difference. And that, in the MI world, with thrombolytics, we sort of said that a 1% mortality difference is the minimal clinically important difference. And so we can do that with this data, and this would show us that we have about a 68% chance that our increased mortality is clinically important. It's like a 76% chance that it's more than 0. But there's a 68% chance that we're causing more than 1 death in 100 people being treated, right? With very little chance of having a significant benefit, and about a 27% chance that it is what we say equivalent. So in this case, we have 6 RCTs, 7 meta-analyses, all using an inferior outcome. The Bayesian meta-analysis shows that there's a high probability of a benefit, but only a trivial probability that this is clinically meaningful, and that there is at least a moderate probability of increased mortality. And I would put forward that these Bayesian meta-analytic methods provide a richer and more interpretable and nuanced analysis of the trial data. Anyway, this one we're going to go through in only a couple of minutes so that we can leave some time for questions. Dexmedetomidine, or Precedex, and postoperative delirium. This is kind of an interesting question because Precedex costs several-fold more than the typical alternatives of opioids or propofol. There have been 14 prior meta-analyses, right? So you can imagine that it is maybe a little bit difficult to get the 15th one published, but we did. And the majority of them have suggested that there's benefit to Precedex, but the largest trial, called Decade, actually showed an increased risk of postoperative delirium. So we attempted to apply the Bayesian framework, looking for all the usual sort of benefits that we've discussed. We had 12 RCTs. You can see the Decade one up here is the kind of a little bit the outlier in terms of not showing a benefit, but on the other hand, it is the biggest trial. Our Bayesian analysis, the pooled effect, was a 33% decrease in postoperative delirium with Precedex, and a confidence interval that did not touch 1. But that, even in the Bayesian world, was a very simple model. It ignored much of the heterogeneity, so that if you actually looked at the next study and you included the between study heterogeneity, the prediction interval is that orange line. And there we see, well, we're really not quite sure, because it is possible that we fall on the wrong side of 1. The orange line extends to the right of 1. Not only that, but this data did not take into account any potential biases that were in the existing trials, and it didn't calculate any the probabilities of any minimally clinically important differences. So, oops, this does not want to seem to advance. Oh, there we go. So there is, when you plot this out, something's missing in the lower right, all the small negative studies, right? This is publication bias. People do this all the time, but in the frequentist world, they just sort of stop. What you can do in the Bayesian world is you can actually model this. And we did some robust Bayesian model averaging, yada, yada, yada. It's a bit complicated. Get some Bayes factors and run your model. And we can show that there was very strong evidence from this data of a publication bias, and that the publication bias should lead to a decrease in the effect size, and you can do all the estimates. And at the end of the day, we end up with this scenario where if we look at DEX alone and say we want to take the perspective of how do we consider the decade study by itself with various priors, we can see that pretty much any way you look at that study, it's going to be a negative study. But we can also look at the meta-analyses. And we can do meta-analyses of all the trials. We can look at low risk. We can do meta-analysis of the Bayesian, of the bias-adjusted models. And we can look at not just whether it's greater than 1, but we can look if does it fall inside or outside this gray line, which would be the lines of equivalency in there. Okay, we can set up our minimally clinically important benefit or harm. And when we go through all these calculations, we find that including taking into account biases such as publication bias, that the probability of benefit with DEX, that it's greater than our minimally clinically important difference, is pretty small, certainly less than 20%. Very weak evidence for any benefit over others. So these conclusions from this meta-analysis actually are pretty generic for almost all the meta-analysis that you look at. One, you want to be aware of the individual biases. In this case, there were biases because of selective reporting, early stopping, late registration. You want to be aware of the meta-analytical biases, such as publication bias, selective inclusion. But being aware of the biases is not enough, right? If you really want to make sense of them, you have to model them, right? You have to quantify them. And you can only do that in a Bayesian context. And when you do, in this particular case, you do the bias-aware analyses, it aligns strongly with no benefit and actually possible harm, possible increased risk of postoperative delirium. And again, the usual sort of, you need more research to be entirely sure, but the signals are certainly pointed in that direction. So take-home messages. Meta-analysis is powerful. A lot of it is not very well done. It's certainly not infallible. Bayesian meta-analyses, I think, is a step forward. It uses all the available evidence. It allows increased flexibility, complex models, makes your assumptions and your handling of uncertainty much more transparent. It minimizes the cognitive biases that get wrapped up in the frequentist analysis of this dichotomization, et cetera. It allows relevant probabilities to be calculated. And ultimately, I think it improves our metacognition, and that leads to better decision-making for our patients. And that's it. Thank you very much.
Thank you so much, Jay. As always, a very informative and always sobering kind of presentation. And thanks for teaching us how to learn epidemiology through rap music. That's a first for me, that's for sure. There's a few questions in the chat. Dr. Rosenblatt, because of the complexity and the challenge of assigning priors, how do you handle sitting on a committee with epidemiologists and non-epidemiologists in advising governments on policy?
I think that the idea of the priors, well, it forces you to actually examine what do you believe, and to be willing to put them down on paper, right? Often we don't really commit ourselves to what we believe. In this case, any interactions I've had, say, with Ines and that, if I've done a Bayesian analysis, I have to put down upfront what the priors are and what the justification is. Now, people may or may not agree with it, and we might look at a different prior. Someone is more enthusiastic or more skeptical, and they can be dealt with. But I think the first step is this idea of being willing to be transparent and write down what it is you believe. And quite honestly, I found that when you do that, even people who are naturally suspicious sort of come around and say, yeah, that's all right. I might not agree with your prior, but I see what you're doing and you are being honest and in how you deal with it.
Benjamin Smith has a question about predicted next study interval. Is it meant to inform decision of whether additional research is justified or inform policy treatment decisions?
I guess it depends what hat you're wearing as a reader. I think it can inform both. I think it can inform researchers and it can inform policymakers as well. You have to look and try and see sometimes what is the concordance between the average and the predictive, and how much are they discordant in terms of trying to decide whether you buy into something right now or whether you want to wait for more evidence. And of course, there are all the other parameters that also have to get folded in, such as the side effects, the costs, and everything else from a policy standpoint. They're going to take those considerations into account, whereas the researcher might just be focused on the efficacy measure. We've only looked at one side of this multifaceted coin.
Okay. Any questions in the audience? Jim?
So why has Cochrane not converted to your particular book?
You know, I think, you know, do I want to give a sort of a politically correct answer here?
Please no.
I think they like their cookbook, right? And their cookbook is pretty nice and simple, right? And you know, it's a little bit like, you know, why does almost 98% of meta-analyses done in sequences, why do they always stop with just the average and never show the predicted interval? You know, I think it's because, honestly, I think it's because we like to think we have the answer. And if we show the predictive interval, we show that, yeah, we got the answer, but there's still some residual uncertainty. And as clinicians, we don't like to have that uncertainty. We would rather sweep it under the rug and pretend it doesn't exist. And I don't know, you know, I mean, Cochrane has invested in a certain paradigm, and, you know, going to change everything, I guess, would be a lot of work. But, you know, I don't, despite what this talk is about, if I had to pick an issue with Cochrane, it would be more with their risk of bias tool, because I think that is such a simplistic look that it does not consider that each trial has its own particularities. It's sort of like, you know, just getting a statistician to do a meta-analysis and not asking the content expert for their input. And when you use this risk of bias tool, it seems to me that we're ignoring all the you know, the specialists that can sort of say, hey, yeah, but in this particular trial, there is this hidden bias here. There's some sort of immortal time or some other bias, which is not captured by just some little, you know, risk of bias checklist. And we have that checklist, and suddenly we feel that everything is okay. There are no biases, because the Cochrane risk of bias has got all little green dots on it and no orange or red.
Jay, we're very fortunate that we have you here and you present to us, and you know, just remind us to look, you know, beneath the surface. Where would one find, you know, more information on, or, you know, one is looking at a meta-analysis on something. Is there a place online that you could go to, you know, that would sort of discuss things the way you are? And that's question one. And number two is, can you imagine ever being able to inform some sort of AI model to do what you are doing with these meta-analyses? That's analysis.
So I think for the AI part, most of it, yeah, you know, I'm by no means any sort of specialist in AI, but a lot of the AI algorithms are actually pretty Bayesian if you get down to it. And so it's not, I don't think it's beyond the realm of possibility that you know, AI could be helpful here. You know, some of the random forests, you know, boost, all these things, they really do depend a lot on Bayesian sort of approaches. I would be cautious about that, because I still believe that the best analyses of data comes from having the right methodology, but also by having the content experts involved. And just depending on the AI without having the content experts, I think is risk to, you know, perhaps you're picking up the hidden biases that are in the data. Whereas if you had the content person there, they can tell you, hey, look, but this is, you know, biased because of this or this. So, you know, I'm sure there's future with just using AI. I would be cautious about not having, you know, content experts, clinicians involved. I think the best thing is to have your methodologist and your clinicians working together. There's lots of online things to help you along the way if you're interested in Bayesian inference, not just for meta-analysis, but for the interpretation of randomized trials. There's a book that was just published it came out in September, I think, or maybe August, called Bayesian Meta-Analysis. So it's a very good book. There's lots of online things too.
Okay, fantastic. Any other questions? Yes, one last question. Yes.
Thank you very much. Very illustrative speech showing the weaknesses of the potential weaknesses of meta-analysis. I was particularly troubled that in your example 2 about thrombolysis, the benefits of thrombolysis did not include mortality. Why they were separated? Obviously, mortality should be, should be included as a factor of mortality, should be included into benefits because it impacts benefits dramatic.
So I don't know exactly the history of why this modified Rankin scale was originally in the very first RCT that ever used it, whatever that was, why they decided to dichotomize 0, 1 versus greater than 1. I suspect that they didn't look at mortality for 2 reasons. One, the first trials or whatever in and by themselves would not have had enough power to detect anything with mortality. And I also think that probably in the stroke world, people sort of think that there maybe are things that are worse than death, right? That maybe if you're in not Rankin 6 of dying, but Rankin 5, where you are totally handicapped and totally dependent on anyone, that is, a fate worse than death. And so that there was this tendency to kind of group all those together. I don't know, I'm speculating. But, I think what we get caught up is these sort of statements that, well, there was no significant increase in mortality from the frequentist point of view.
That should be expanded better by the authors.
But it can only be expanded if you are looking to estimate the parameter of mortality. But if you're in the frequentist world, you're just looking at whether something is statistically significant, yes or no. You're not estimating the actual parameter and the probability of increased mortality. And I think that that's one of the drawbacks of traditional statistics is, in the medical world, is that we look at p-values and we've married them in with null hypothesis significance testing, and we've forgotten about doing parameter estimation with the confidence intervals around that. And that's what the whole Bayesian idea is to try and estimate what these parameters are. And when you do that sort of estimation, you might see that there's a 75% probability of increased mortality. It's not, the 95% that you like to see before you're going to convict someone, but nevertheless, it's a 75% probability of increased mortality. It's like, someone tells me it's not going to rain today. That's fine. If they tell me there's a 75% chance it's going to rain today, I might take my umbrella. In other words, if I have the 75%, as opposed to just some sort of categorical statement that doesn't give a probability estimate, it's going to influence how I behave. So,
I'm just gonna, sorry, I'm gonna interrupt and let you have the conversation separately because it is past the hour. So I do have to close the rounds. Jay, as always, a pleasure, very informative. Really appreciate you speaking to us today. So have a great day, everyone. Bye-bye.